is present here. I'm very thankful to Apratim that he has asked me to deliver this lecture from epilydema to precision navigating the pressure maze with venous stenting in IIH. So he has made very clear that IIH has been quite an established form of treatment. The venous stenting has been quite an established form of treatment in IIH, along with the medical management and surgical management. And what I've seen is that he has a very fine art of giving very fancy names throughout the whole day. That each topic has been given a very nice and picky names, which makes it quite interesting. So probably there's some technical glitch here. So I'll not discuss too much because as neurologists, all of you know the signs, symptoms, and the basic things about IIH. But what I would say, as I has mentioned, that headache is one of the neglected area, and so is IIH, because most of the many cases, what I've seen that they come to us for treatment, like stenting or something, because being an interventionist, I'd be more concentrating on the stenting part, that the patients are relatively in a bit of an advanced stage, that probably it was missed by the radiologist while reporting the MR, or probably it was a clinically mismanaged. So many cases what I have seen that they come to us when in the verge of losing their vision, and when we go for the treatment, it takes a lot of time to get the vision back, or they may not get their vision back completely. So that's one. So symptoms obviously is the headache, and the clinical feature is especially because I had only one patient treated the male patient, but rest all the patients are female, and they're a little bit overweight and in their early days. So other symptoms like pulsatile tinnitus, back pain, neck pain are quite less. The blurred vision is again one of the most important clinical symptom, and so headache with blurred vision should raise the suspicion of IIH. Obviously, then the patient go for an ophthalmological examination, which should demonstrate a papilledema, but a very small percentage of patients, the papilledema may not be there in the early stage. And then we go for an MR. I've come to these findings, and obviously the CSF manometry remains the gold standard. And when the CSF pressure in lumbar puncture is more than 25, we should be suspecting IIH. Pathophysiology is obviously there is some sort of CSF dysregulation, be it in the formation or in the absorption. But most likely this is in the phase of absorption, which causes increased venous pressure, and it gets reflected in the eye, causing papilledema and headache and other symptoms in these patients. So obviously there are three types. One is typical IIH, where there is young and obese female patients with high BMI. In atypical IIH, the patient may not be obese, and in fulminant, obviously when the patient is losing vision very rapidly. Now, MR actually remains clinically, imaging-wise, the MR remains the gold standard, and we should not be missing the findings of IIH when the clinician may be misguided if the MR is not reported properly. So it has an acronym with STOP, where the sella, we should see the transverse sinus is emptied, or the pituitary gland is quite flattened, and the sella is large because of high pressure, which was there for quite a long time, and which gets reflected in the orbit and the optic nerve, where the optic nerve sheath gets distended and the posterior globe gets flattened. And obviously, why it happens, it's because of the transverse sinus stenosis, although it's not been proved beyond doubt which comes first, whether the transverse sinus or it is the consequence of raised ICT. So these are the MR findings which should not be missed or cannot be missed here. We can see that in young female, where the sella is quite enlarged, we don't see pituitary gland in this place, probably it is flattened. And we see the tortuous optic nerve with flattened optic disc. And in these patients, obviously the radiologist also should do an MRV to demonstrate that the dominant sinus has got a stenosis here, and the opposite sinus is probably congenitally hypoplastic or absent, and the dominant sinus has got stenosis, which led to these findings of clinical imaging findings of IIH. So, obviously, there may be two types, which is normal and the fulminant type, where there is no immediate threat to vision, that those patients can be treated with medical management. But when there is a very high, rapidly deteriorating vision, then the patient should not only be on the medical management, and we should be searching for something else so that the high pressure goes down rapidly to save the vision. Now, these modified Dundee criteria, obviously, we should remember for a handy diagnosis, like symptoms of raised IIH should be there, like headache, nausea, vomiting, and there might be 6-nerve positive because of raised ICH. There should not be any other localizing sign except the 6-nerve. Neuroimaging obviously is very important role to play for the diagnosis of IH, and obviously then it should go for CSF lumbar puncture and CSF pressure measurement. And obviously the CSF should not be having any other signs or findings of meningitis or other things. So I would now go directly to the venous stenting, because we know that there is surgical alternative like lumbar puncture, the peritoneal shunt or ventriculoperitoneal shunt, but obviously they have got their own challenges and problems. So and that's why this venous stenting came out to be an alternative mode of treatment, which is less invasive obviously as compared to VP shunt. And it's proved over time that it is highly effective in mitigating the problems of IIH. And there has been a nice meta-analysis which was published in 2015, and which showed that the overall complication of this venous stenting is really low. And if it's done in experienced hands, it should not be there. And the most dreaded complication is being subdural hematoma and subarachnoid bleed if the stenting stent has been put in a very small sinus. The oversizing is done for the stent, and in those conditions they come. Otherwise, it's not a problem. And around 10% of the patients who does undergo venous stenting might require an additional problem because of treatment failure, and which comes because of other issues I'll be discussing there. And obviously, when the stent is indicated, when the pressure gradient across the stenosis in the transverse sinus is more than 10, but some people give around more than 8, and that is when we should go ahead and put a stent. And if it's not, the gradient is not that high, then obviously there is no point going and putting the stent. Now, this was the first case of angioplasty we tried long way back in case of venous stenosis and IH, typical IH, which we published in Neurologic India, and showed that when the patient, sometimes the patients, I have had 2 patients where they did not want any stent. So we did only angioplasty, and the angioplasty, as you can see, that all the signs and symptoms of imaging features of, this is a BAVF, of IH was there, and we did only angioplasty. So these are the balloons, this is a very simple procedure actually, and obviously you have to puncture the neck, and that makes your procedure very simple, not through the groin, because it's very difficult to push the device from the groin. So it's very easy to puncture the neck jugular vein, and then go ahead and put a balloon and dilate it. So in this patient, although it was not my intention to just do angioplasty, this patient did remarkably well actually. So it was done, I think, 6 years back. First case of only angioplasty I've done, and this is the follow-up. As you can see that both the transverse sinus maintained it very nicely. Otherwise, there is a tendency of the transverse sinus to come back to its original position because the dura is a very tough structure. And this is what we see after the stenting. This is 6 months after stenting. As you can see that the sella, enlarged sella, is going back towards normal. The optic nerve remains becomes normal, and this is the result. And you can see, sorry, this gets reflected in the ophthalmological examination also. And this is the follow-up. We also have done the DSA. So yeah, so that's the DSV also we did in this case, because I was not really sure that whether this is really working, and as you can see that the sinus has been maintained well. But unfortunately, the patient came back after 5 years to meet again, having the symptoms of, and at that point of time, again, the thing record, I didn't put that case, and we had to put a stent for resolution of the symptoms. So angioplasty is not a very good durable treatment for this one, the stenting. I have had another young lady who is a doctor, and she also didn't want to put a stent, and she's on follow-up, she's doing well. Now this is one, let me go to the cases. Stenting, as usual, young female who was on acetazolamide for quite some time, but despite that she had deteriorating vision. So obviously, the problem of the stenting is that you have to put the patient on antiplatelet and anticoagulant. And this was a finding where the optic nerves. This is a very typical finding. There's nothing much rocket science here. As you can see that there is a high degree of stenosis in MRV, and obviously that is pupilledema, and you go ahead and put a stent. Now, obviously, these are just the steps how we put it. We take a very big tube inside the transverse sinus and take the stent and measure the pressure before and after stenting, and immediately the pressure gradient goes down and becomes normal after putting the stent. So this is how the stent looks like in the transverse sinus, and after putting the stent, again we take the microcatheter to measure the pressure. So in this case, as you can see that the before and after, there is a huge pressure gradient before and after, before and which has been normalized after putting the stent. So case 2, again a young female who had who first presented in April 2024, and then at that point of time she underwent LP shunt. So this case is still admitted in our ward, and at that point of time I do not know actually about the history. At that point there was no history that they referred to us, and the LP shunt was done. So then she had some improvement, And that time, obviously, there was stenosis, bilateral transverse sinus, and the CSF opening pressure was 83. So this is the MR venography, which I can see now actually. What we can see, there is a stenosis here, and she had stenosis. Actually, this was done I think 2-3 days back. And who had a stenosis here and very tight stenosis here. Actually, when you pass the devices, then you can understand how thick the dura is and how much was the stenosis. So we have put this stent, and now the patients obviously her headache went down. She is still there. Her headache went down, but the vision is remained more or less the same. She developed, actually, our ophthalmologist has seen, she developed optic atrophy on both sides, right more than the left. Her vision is now, she is able to see, but there is a lot of diminution in the acuity of the vision. Now you can see that not only the stent works, you can see that how tight the stenosis is. So after putting the stent, you have to open it with the balloon. So this is the balloon inside the stent, and then only the stent opens completely, and you have had problems solved. Case 3, again the patient had a bilateral stenosis. The patient had a 1-month history of deteriorating vision and had edema, and as you can see that there has been quite, this is the right and the left side of the pressure, a huge pressure difference, but we do not choose both the transverse sinus for stenting at one go, because the dominant sinus, that means the superior sagittal sinus, is coming and draining into that particular sinus, is called the dominant sinus, and we first tackle that. And in most of the cases, the dominant sinus stenting resolves the problem, except in one case in my series which required bilateral stenting. The case 4, so all these patients, as you can see, they are in their 2nd and 3rd decade of life, and a history of very short history with sudden, very progressive diminution of vision. So the flow of event is more or less the same, and as you can see that there's a very high, very large anti-stella and posterior flattening of the optic nerve. Again, same. This is quite a long stent because the patient has got had a, as you can see here, that from this part to this part, which had a quite a long stenosed area, so you have to take the whole area stented. And as you can see that we also put a balloon here, and this is after stenting, and this is the dominant sinus. And as you can see that her opposite sinus was hypoplastic or absent. So this is the pre and the post stenting pressure measurement across the stenosis, and you can see that there has been complete resolution of the pressure gradient. So I think that is one of the cases that I showed, because these are basically the reputation of the index cases. The learning point here is that we should be treating the whole of the stenosis, and the dominant sinus should be tackled. So now this patient, as you can see that, sorry, yeah, this is one case who is little bit in the later period of her life. She is around 50, and who had headache around more than 4 years, and then presented with blurred vision for 5 months. And this is the stenosis in the right transverse sinus, and in all the cases the stenosis remains in the dominant sinus. So that is very important. If the dominant sinus is not affected, usually the diagnosis should be thought differently. So this is a venous pressure measurement again. As you can see that there has been significant pressure difference. Now, how do we follow them up? Obviously, follow-up is mainly clinical follow-up, the resolution of headache, the resolution of edema, and the improvement in the venous function, because we do not go ahead and do the imaging very rapidly. And obviously, after 6 months, 3 to 6 months period of time, we should do at least one MR cross-sectional imaging with venography to see that how the stent is doing. And nowadays, we can go for the venous MRV without losing signal, and all. There are very good MR sequences with which we can go ahead and do the imaging non-invasively. So obviously, depends on the papilledema grade, how we follow them up. So obviously, the mild cases where might not be required the stenting or BP or admission can be managed only with simple with medication. So obviously, we should be seeing these patients for quite some time, because in our series, we have seen that after angioplasty, after 5 years, the patient came back, and she was on Diamox for quite a long time. And we had only 21 patients in last 12, 13 years. So that actually shows that a large majority of the patients who are not coming to the clinicians properly at the right point of time, or probably they are not being diagnosed properly and not being given the treatment what is required, or they probably a small percentage of cases which require stenting, and the other cases probably are resolving with medicine even only. So that is, we do not know that exact figure. Now, 2 patients, as I told, that we did angioplasty, but one required stent later, and rest 21 patients with primary stenting only. We have had no procedure-related complications, touch wood, all improved, except one patient who completely lost vision. She was from Bihar, and her vision completely became normal, and then she stopped the antiplatelets and anticoagulants. So that is a problem actually, because we have to keep the patients on one single antiplatelet and anticoagulation for at least for 2 years. That's what I have also discussed, because there is no clear consensus that how long you should be continuing the antiplatelets and anticoagulants, but at least 2 years, what my other colleagues also follow, and which is being published. So obviously the first line of treatment is the medicine, and despite the proper medical management and the proper dosage, because many a time I have seen the patients come with 250 either OD or BD dose of acetazolamide, which is definitely not a proper dose, and they require very close follow-up, and we should not be stopping acetazolamide just after putting the stent. Usually I keep it for 3 months at least, and then gradually taper down and stop it. VP and LP shunts are definitely more invasive, and because most of the patients, they come to the neurologists, and they also like to do less invasive treatment as compared to VP and LP shunts. And what I feel is that venous sinus stenting is more physiological, because although we do not know the exact cause and effect relationship, but it appears that because of the venous pressure and high venous pressure, which leads to the decreased CSF absorption, is the main culprit. So the venous sinus stenting appears to be more physiological, and this procedure, because it's done on the venous side, it's quite safe, and the problems of the procedure-related problems are very few. So, as a whole, what I'd like to mention is that these patients, if they are not doing well with the medicine, should be the venous sinus stenting should be a good alternative. I have one patient who had a very high CSF opening pressure, but she did not have any venous sinus stenosis. So that again reminds us and made us think in a different way that probably there is some alternative mechanism also which works. So we took the venous pressure gradient. She had mild stenosis, but there was no gradient at all. And then that patient also underwent BP shunt, because we can put stent in that particular patient. Yeah, thank you.
Thank you so much, sir, for the enlightening talk. I would request our respected panelists
we are proud students from your side basically. So, Professor Kapil sir, we have been learning about IIH since our beginning of our medical curriculum. But as we have evolved in our thinking, sir, I would like to ask like optic nerve sheath fenestration, then shunts, now venous sinus stenting. So, in your practice, like what or for us as students, what is our take-home message? Should stenting or venous gradients be preferred over other invasive procedures? Your take on that?
In fact, if there is obvious stenosis, you will have to go for stenting. That is true. But you simultaneously have to see the progress of visual deterioration. This is very important because this headache is continuing and you can manage it in some way or other. But if the visual deterioration is progressive and quite considerable, we will have to think of something else. And if in those cases there is no obvious stenosis in the drainage system, that means the venous sinus, then we will have to go for this fenestration. Otherwise, this stenting, which is often escape our attention, this stenosis often escape our attention because a patient coming with progressive headache, and we often miss the papilledema, the early papilledema. And in those cases also, we do not often investigate for any this drainage anomaly. So these are the very important things we must realize. And if the visual deterioration progresses and there is no stenosis obvious, of course we will have to go for fenestration. And if in most of the cases where we do not do this venous angiography, we obviously don't think of stenting. But now you see that in experience and the stenting is so marvelous, gives so marvelous result in without even fenestration. So this is very important. We must think.
Thank you, sir. Atunu sir, my question to you, sir, is we have seen cases, sir has also demonstrated, where there has been significant vision loss, where there has been optic atrophy, but even after stenting, it has been reported, and sir has also shown that there has been some reversal. So your take on this modality of treatment, like should we offer in the initial part, or even cases having optic atrophy in IIH?
Thank you. As Professor Vishwas was talking about, there are two, three things which we need to consider while choosing a therapy. One is the availability and the expertise. The optic nerve fenestration is very difficult in this part of this country because many of the patients who are previously, when this stenting procedure was not available, not widely done by many experts, we were stuck because the loss of vision was not. We didn't have anything to offer for these patients. Sometimes I remember quite a number of patients are referred to PGI for getting the optic nerve fenestration. So the vision loss is dangerous one, and for IIH patients there was almost no hope, particularly those who are having a permanent IIH. They developed over a period of months. Within a month, they develop a severe vision loss. So in those cases, this probably is offering a hope to the patients to gain their vision. But of course, there are many IIH patients who might benefit from medical therapy. All patients do not require PPI, this transverse sinus stenting. They do well with medical therapy, acetazolamide in a good number of patients. And of course, when there is a vision loss and there is vision is jeopardizing and vision loss, not loss, vision is diminishing. And if there is a stenosis detected in the MR venogram, this procedure is found to be one of the easiest way to prevent the ongoing vision loss. And in our center also we have done quite a number of patients because now this intervention is widely available in this city at least, and there are a number of young neurologists and neuroradiologists who are available. So this is probably, but I don't know, Professor Chaudhary is there, whether there was any evidence available as head-to-head study between the optic administration and this, or between the Stenting and this stenting. But obviously we have seen some of the remarkable improvement in some of the patients who have undergone this stenting in patients of
Can I have since this stenting things are, I think, is exciting and is relatively new. I think this part maybe last 1 decade or so. So previously we have seen many patients actually who have done repeated LP, maybe 7, 10 or kind of things, and we have seen that I can say 8 out of 10 patients will recover about maybe 3 or 4 patients, and there is sustained improvement actually. There is, and maybe I think acetylazole maybe for 3 to 6 months, and follow up actually they have recovered. So I was wondering whether we can give that kind of actually opportunity to the patient, maybe 2, 3 or 4, and once the opening pressure that normalized for maybe 2 consecutive CSF lumbar puncture, I think many of the patients can do well even without this kind of thing.
for me.
So I was wondering what is the
To
cutoff
control
point?
the
on-
headache, that
Yeah.
is a good option, but
Yeah.
when the vision is at jeopardy, you cannot take risk of doing only by continuing medical therapy or by doing repeated lumbar puncture. Then you have the option of giving this stenting, because this gives a good relief to the patient.
Yeah.
So very nice lecture, Sukalyan, and I'm impressed by your kind of cases that you've done. The question is, there are 2 or 3 basic things we need to understand. One is this: that is the stenosis which you're seeing, is what is the pathologic mechanism for that? I mean, is it the cause or the effect, right? So if you are thinking that it is a cause, then obviously you are justifiable in doing an intervention. But if you think that that's an effect of the IIH, that because I remember that there is a very startling case which was shown by Dr. Girish of Nimhans, that there was a complete stenosis. Ashish also remembers that case, right? And the moment they did the CSF, the lumbar puncture, the next day they repeated the MR venogram, and the sinuses were normal. So what we call as stenosis may be an effect of the IIH rather than the cause of IIH. That is one point. The number 2 is this: obviously because the disease, this kind of patients are limited in number who are sent, as you said, late to the this thing. So there are not many trials, and especially the double-blind randomized trial, which is the gold standard, right? So it is only based on anecdotal reports. So we have to be very strict with ourselves in kind of delineating the effect by having a stringent outcome measures, right? How much the vision has improved, how much the field has improved. Right. We have to see that it's not just a kind of, because if you are doing an intervention, generally the tendency by the doctors and the rest patients is that they tend to seek more relief. They report more relief, right? So that is one point. The third point is this, that obviously the comparator. I think personally I would say that despite in Delhi and AIMS and other people were doing a lot of optic nerve fenestrations, operation ophthalmologists. I have found that to be pretty, dismal results. I mean, they would offer to about 20%, in my view, 20-25% relief with optic nerve fenestration, and the headaches will not go. Headaches, the vision will be this thing, headaches will not. And I will say to Dr. Bishwa that even headaches are also very troublesome for some of these patients. It's not benign. That's why the term has changed to idiopathic from benign intracranial hypertension. So headaches can be actually killing for. I have a lot of patients who are having not the visual problem, but the headache is so monstrous for them that they are not able to live normally. Right? So I think that this gives that we should see it in such a way that this gives an opportunity for us to have an intervention which might alleviate the symptoms. And if we have, like you, and you can train others also, So they have an opportunity to access this treatment, and we should have a stringent outcome criteria, and you should document that and have more publications out of that, so that becomes a standardized treatment.
Yeah, as far as like the literatures now, that we have the comparison between the stenting and the medical management alone, and obviously the stenting showed a better result in a very small percentage of cases. The meta-analyses are not many, but again, it showed a great promise despite around 10% of the cases where they required additional like LP and all those things. So obviously, because this is an invasive procedure, it cannot be the first line of treatment. Obviously, the medicine is the first line of treatment, and these patients should be followed up very closely because the problem is that they might lose vision very rapidly over days. So in those cases, and I have also told one case that where she had very high opening pressure, but there is no stenosis and there is no gradient. So obviously the cause-effect relationship is not established completely, but if everything matches together, the clinical signs of raised ICT, deteriorating vision, the patient is having a stenosis in the dominant sinus. So that's very important, in the dominant sinus. And then those are the cases probably you can go for stent.
Yeah, and I think that his point is also should be well taken, because there will be situations where you want to have some time for leverage and making the patients and relatives understand the procedure, invasive procedure, making up their mind, and during that time you can do a couple of LPs to save the impending visual loss. So that still has a role in that situation.
Yes, this is very important from our part to follow up. The follow up is the most important thing which we often do not do. And what Dr. Chaudhary has told us, that is etiological aspects, the spasm of the transverse sinus. This is very important, that after a few LPs, it is appeared. So this should be kept in mind. And even in that case, we do LPs and we do medical management, and we also do follow-up for the venogram, and we see what is the prospect and how their spasm goes.
Yeah, so imaging-wise, one part is a bit difficult to understand is that if there is raised pressure which is causing the compression of the venous sinus, it cannot be a focal one. It has to be the whole sinus should be affected. But if we find a focal stenosis, so that might be unlikely it is because of raised ICT, or probably because of the stenosis, raised ICT is happening. Why there should be only a focal area which is getting stenosed. In
And
case
also you are
of
talking
generalized
about the gradient,
problem.
pressure gradient across the stenosis.
Yes. That is very important. So if we do not do until unless this gradient is at least 10.
You all remember the hype about doing the stenting in MS patients.
Yes.
And that was started without much evidence because of a single man, propagating it, and then it became raised in wildfire. And in India, we have been doing left and right and center this kind of procedures, right? For the
No, but
foreign
that stenting did not gain any popularity actually.
Later it fell into disrepute, but I know that a lot of people, they have series of 100 and 200 patients coming from all the states. So we should be careful. I think what I'm suggesting is this, that we should be careful, because still we don't know exactly the cause and effect relationship, and therefore we should document. It might be providing a good effect for the impending visual failure. Therefore, our outcome parameters should be very stringent, and we should be diligent in noting that and observing that effect.
Absolutely.
I have two comments. One, for an impending visual threat, patient waiting for either optic nerve sheath fenestration or a venous sinus stenting, in a very selected patient, maybe for a time-saving measure, a short course of corticosteroid may be warranted, but there are difference of opinion regarding that. I want an opinion of house regarding this. And second is, patients who are not tolerating acetazolamide, topiramate may be a safer option. But has anybody used a combination of both in treating IIH patients?
Steroid is considered to be, if at all to be given over a very short course of time, and that is to give relief to the patient, to the headache, and also to some extent to the. But here long-term steroid is It's contraindicated. And second option you told about was
Topiramate.
topiramate. Dr. Viveklal is very fond of giving both together. He always suggested because the headache component gets relieved with topiramate to some extent. But I don't think that.
No, that's a very weak this thing, but you can give it. I mean, we all do it. I mean, at times when the patient cannot tolerate a high dose acetazolamide, we do it. But obviously, you will stand the risk of having this carbonic, anhydrase inhibition side effects. So you can do it. I think adding a little bit of diuretic might also help because if you add a little bit of say furosemide or so there is no data. I mean, there is no evidence-based data for that, right? All this anecdotal. So we need good studies. I think this is an emerging field in India. We should have especially the academic centers who are doing and who are interested in research and headache. I think you can take it up. And in fact, we did one study and we found out a very very easy way of. Ashish, can you tell it about the optic nerve?
So we did a study where we measured the optic nerve sheath diameter by MRI and transformator ultrasound, and we found that it correlates with the intracranial pressure, CSF opening pressure. And although we did not do that, but that can be used as a tool to monitor. Although I believe the best tool would be visual field, which should be monitored regularly, as you showed in your slides. There is a protocol which should be followed, and so the patients can be shifted to an intervention early.
So in short, there is a huge potential for youngsters to pick up this topic and show to the world that something new. I think that's a great potential.
On the other hand, topiramate increases the intraocular pressure. That will be the other side effect, and that may cause visual dimness, especially when we are using it as an anti-seizure medication. And that should be mentioned and we have to check up the intraocular pressure periodically.
Thank you so much, sir, for the effective talk and its